we should let's try to recap what we did yesterday before I always like to um review previous lesson before I move forward. That's what I like to do. So yesterday we talked about first aid, and we looked at professional development, also the importance of a CHCA actually developing himself or herself. In fact, not only a CHCA, anybody in the healthcare sector, you have to keep upgrading yourselves because times are changing. Technology is metamorphosing, is moving from one stage to another. So if you are stagnant, then the times will move and you will remain. People will move and you would remain. So it's important that we keeping ourselves updated. We keep refreshing our brains, build upon what we have learned, and then in the health field. So hence we talked about that professional development, and even in the course of that, that was yesterday, we talked about one area of specialization. Like I said, that I advise people to actually keep moving ahead and then taking trainings. Moving ahead so that they can do better, specialize in a particular field, because you and I know that once someone is a specialist in a particular field, you earn more. In terms of salaries, you earn more and every other thing comes with it. So it's important that even as we are CHCs or those that are CNAs or, or therapy, in any of this, try to specialize. Yes, Jovita, it's nice to have you. Hello, Jovita. You're welcome.
Yes, thank you, ma.
Right, welcome. I was looking out and I was wondering that whether Jovita will not join us today. That's nice. It's good. All right. So, good evening. So online courses, webinars, we should never be tired. I want to really appreciate those that have taken steps. We have people even here on this platform that have done more than one. They have venture CNA, caregiving. The beautiful thing of you having more than one health qualification is this, because it gives you a higher chance. It gives you an advantage. Whichever way it comes, you have a job as a caregiver, you are there, you have what it takes. You have a job as a CHCA, you are there, you have what it takes. And you have more opportunities when you have more than one healthcare certification. If you have one too, you will equally have opportunities. But it's just like someone having more than one thing, you have broader opportunities because anyone that comes, a wider range, anyone that comes up, you are available for it. So that is practically what we did. I just want to have an overview quickly, and then we'll talk about reporting and documentation briefly before we move over for the practical sessions. Today, our practical is purely going to be on first aid and CPR today, because if you look at the modules, your course outline, you would see first aid and CPR, which is very important. Yesterday, we ran through the theory, and then today, we try as much as possible not go through all again, elevate, do this, because we already have the pictures aligned with it when we're talking about it, and you will have the slides. But all other very important skills, things you need to know as a healthcare assistant or a healthcare practitioner, we are going to look at it. So we talked about sprains, how to deal with sprains. We talked about the RICE, the acronym. We are going to get to learn more acronyms today. So it's important that when any acronym is being talked about, it's better you have the full knowledge of it, which, trust me, you are going to have the slides. Any part of it that you miss, you get the slides, you get the recorded versions, and we have the videos, everything. You will be well equipped to take the exams. Hence, you see, like those of you that have been on the platform, hence you've seen so many people actually rejoice and, they are happy. They are happy because they actually took pains, burnt the midnight oil to ensure that they go through the slides and then they ask questions, maybe later on when they get through the slides, if they are unable to understand any part they asked. So we talked about sprains yesterday. We also talked about how to deal with burns, the different degrees of burns, the first, the second, and the third degree burns. And two, we also talked about the first aid measures, how to recognize these burns depending on the level of the skin. The first, the epidermis, the dermis, and the hypodermis. We talked about that yesterday. We also talked about stroke too, which is very important. We talked about stroke. And when we talked about the stroke, we talked about FAST, I beg your pardon, FAST, and which is also another acronym. Face, look even, the arm, the speech, is the speech okay? Is it slurred? And then the time as well. So all these things are things that we need to just look at. And so that it would help us while taking the exams. Talked about the signs and the symptoms, and we talked about the stroke itself, that it's an illness that affects the brain, that affects the blood supply to some parts of the brain, either interrupted or reduced, or does not contain enough oxygen or nutrients that is required. Talked about that. We also looked at what else? We looked at heart attack. Very, very important. We talked about heart attack, what it does, and how we can act very fast. The most important thing as caregivers, like we said, as first aiders, you are not actually treating. You are just helping as much as possible to reduce the severity of a particular condition before the arrival of the paramedics. Very important. We also had the first aid for choking, which we dramatized, which we had a video. We said what to do, the 5 slaps, the Heimlich maneuver, what to do, the abdominal thrust, and the 5 slaps. We talked about it yesterday. And then we looked at CPR2, mouth-to-mouth resuscitation, that there are practically 5 steps, things you need to do as it is there, 4 steps rather, that it is there. What do you do first, second, third, fourth, as we saw on that video? So, totally, overall, as a first aider, we also looked at the qualities you need to have. You need to be patient, you need to be enduring, you need to be sympathetic, you need to be cheerful, and a whole lot of things are qualities that we need to imbibe, not only as first aiders, but we should make it part and parcel of us. It should be a part of us in our relationship with people that are not even vulnerable, in our workplaces, all aspects of our lives. We also did say that it's important that you check that a dead person cannot actually deal with a person. That's like a dead person is of no use. That's it. It's of no help to anyone, or cannot deal with anybody, cannot do anything. So it's important that you check the scene. Good. Today we are going to have practicals of first aid, and then we are going to see these things. Unusual noises, recognizing emergencies, what to do when you come face to face with emergencies, and so on and so forth. So today, practically, we are going to just be looking at in a few minutes before we delve into the practicals. We are going to be looking at reporting and documentation. Reporting and documentation. That's what we are going to be looking at today. Okay. Remember, one of the modules that we have. Okay, Nora, it's nice to have you. I can see you, Nora, and Mildred. Yes, I was just asking myself what is happening. All right, what's happening that I've not seen the other participants. So Mildred and Nora, it's nice to have you. So documentation is very important. Reporting and documenting is very important in our careers as healthcare assistants. Your role in documentation is vital. It's very important for patient safety, quality of life, or quality of care that is rendered to a patient, and effective communication. Now, you have to keep documenting and reporting whatever needs to be in the course of your relationship with the patient. Like we already said, I said earlier that when we are dealing with patients, a CSCA is very close to the patient. A caregiver is about the close, a certified nurse assistant, a certified healthcare assistant, whichever, all those duties are very, very strategic duties or jobs because you have the first-hand interaction with the patient. And so what you document matters. What you say you did is very important because it's based on your documentation that will be put together to see how to help the patient get better, to see how to render the best care to the patient. So reporting and documentation involves you recording the information of the parents, your observations, which is most important, maybe after taking medications, what happens, and then the care you provide, to ensure continuity is very important. That's why we have documentation. And do not also forget that sometimes when you get to work in these places, you work on shifts. You work on shifts in some, not all. So if you are actually working on shifts, another importance of documentation is you'll have to hand over to the next person that is taking over from you. The registered nurse will have to do the movement around the wards. That's move rounds. That's how they call it. I will have to move around, see the patient who is handing over. Okay, where did you give the medication? How many injections? Look at the folder if it's a hospital setting. Anyway, look at the folder. Okay, 3 injections per day. Okay, you've given the second, so now by so time we'll give the third, and so on and so forth. That is how they do their rounds. So it's based on what is documented that there will be continuity and follow up, and it will enhance effective communication to see as to make the patient better. Now, accurate documentation is crucial for effective communication among healthcare workers. Also, legal aspect of it. Looking at the legal aspect of the whole thing is very, very crucial and very important because lots of times, healthcare workers and practitioners have actually got themselves in trouble. They've actually lost their jobs one way or the other because of the fact that they are not able to actually document what has to be on time and properly. So that's why, to safeguard yourself and also to ensure that there is continuity, there's communication, you have to ensure that every thing concerning the patient is properly documented. This is very important. Okay. Now, what are the objectives? What are the objectives of documentation? That's another thing. Why should we document? What are the objectives? We have already said some of them, but one, to ensure continuity of care, very important, so that the healthcare team can work together, can be on the same page. We also have the legal protection too. It serves as a legal record of the care provided. Quality improvements. It helps identify trends and areas for improvements in healthcare. I beg your pardon, that is, sorry, identity is supposed to be identified. So just permit me, because I'm sending these slides over, I don't want any mistakes on them when I send them to you. So let's go back. So as I was saying, it helps identify trends and areas of improvements, because following the care plan, they'll be able to see areas of improvement. They'll be able to maybe carry out an assessment as to know how is the person improving, or is the person actually improving, or the person is deteriorating, which of them? This is very important. Hence, the assessments and the documentation from you, the certified healthcare assistant. Now, quality improvement. Okay, we've talked about that. Communication. It facilitates clear communication among the providers, among the patients and family members. Communication, the need for communication cannot be overemphasized. Like we have been saying from the very first minute, I keep telling you that communication cuts across all the modules for this training. It cuts across all. There's hardly none of the modules that communication is not found. Okay, now what are the components of this documentation that we have talked about? Let's look at it. Components of effective documentation. effective documentation, we have accuracy. Good. Now, accuracy is not just all about, documentation, I beg your pardon, it's not just all about writing this happened and that happened. No, not at all. It involves a whole lot. Accuracy ensures that whatever information you write is correct. That's the first thing. And it reflects the actual condition of the patient and the care you have given. That's to say, before you take your hand and write anything, you document anything, be sure that they are the information is factual, like is the truth. Let's move a little bit away from the health sector now. In anything you do, whatever you do, anything you document, I tell people, anything you take your hand to write, it's even easier to say it. If you say, well, it could be I said, I did not say but anything you take your hand to write that you document has to be one, the truth, has to be correct information. Very important, especially when you're dealing with a vulnerable person, you're dealing with someone that actually needs care. So your information can go a long way in either helping the person to get better or helping the person to get worse. So documentation is very important. Also, documenting vital signs like we would see when we have the practicals. Like I said earlier, before others joined me, I said that we are going to have our first aid practicals today, purely first aid, purely what you can do as a first aider in your environment, with the patients around you. By next week, God willing, because we have the Wednesday and Thursday, today is for the first aider, and then next week is for the clinical aspects proper. That's where you talk about the proper hand wash, you talk about the vital signs, how to check, how to record, and a whole lot of things. Practically, the clinical aspect is what we are going to be doing Wednesday and Thursday next week. Today, we are going to take the first aid aspect of this training. So it is very important when checking vital signs, like we'll get to see that next week, you have to document immediately after taking them. There are people that do some of those things. Maybe when they check the vital signs and another thing comes up, maybe something just intercepts them. You have to do this or you need to go this. They leave what they are supposed to do and they come back to document, which is not very good, because at the end of the day, it's most likely that you may make mistakes. That's the truth of it. It's just like I get to see some seamstresses when they sew and or tailors, when you go to them, they take your measurement. I used to wonder that time when I go to, I'll be wondering, how do these people actually coordinate all these things? Because they would take your measurement, they would measure the bust, they will measure the length, the waist, they'll measure everything at once and they will write it. And because they do all these things, most times they give you clothes. Sometimes, some of them, they give you clothes that are out of proportion, clothes that are what you ordered for versus what you got, because of some of these things. So now, what am I saying? When you take vital signs, it is very important that you take the measurements at that particular point. That's you document the measurements at that particular instance that you have taken it. Then make sure you include all the necessary information, such as the assessments, interventions, patient responses, everything. You document it properly. Not just what was done, but how the patient reacted. Because sometimes we get to have unfinished, we cut short our documentation or our reporting. This is what happened. You just say what happened. You don't follow it up with, okay, this is what happened. And because this happened, this is what I did. Good, that is a comprehensive report. Those of us that are already managers on this platform, that's a comprehensive report. What happened? Okay, that happened. Did you take any action? What did you do? It happened. I did this, and you follow it up with the documentation, which collaborates what you have already said verbally. It goes together. That's very, very important. So include all the necessary feedbacks, all the necessary information that they actually need. Okay, timeliness. Documents information promptly to ensure that it reflects the current status. Just as I said, entering notes after each patient's interaction rather than at the end of the shift. Yes, this is another thing. When you wait till the end of the shift, because by the grace of God, some of us will actually be professional CACs. So do not wait till the end of the shift before you record some things. There are people that actually do that. Hence, it's very important to take notes. Document immediately. Don't say, okay, when I am done. Why? Because we are most times busy. As a CACA, you will be very busy. As in busy, because you have to attend to a lot of things. But at the same time, in as much as we are busy, it is important that we follow what we have to do, as in follow it judiciously. We follow it and ensure that it is done. We order our activities. We prioritize the things that we need to do. We arrange them and we take them as per the arrangements. Yes, we agree that some of these things actually happen. Some things just prop up and just come in, you know, but as it stands, it is very important for us to note some of these things. We have to ensure that we enter our we document as at the current status. Enter those notes at that particular time. Now, use clear and concise language. This is another one. Do not use medical jargons. Do not use those very, you know, come down to use clear and concise languages, like I said. Avoid those big legal, I beg your pardon, medical jargons. Yeah, those medical terminologies that you now use. Instead of saying maybe, come down to the barest minimum, like we can see there, the patient seemed unwell. Specify. Seemed unwell is a broad thing. Unwell as a result of what? So instead, why don't you specify the patient exhibited shortness of breath and elevated heart rate? This is important. Okay, so
I'm lost.
use of can we hear? Are we together? I pray network
Yes,
doesn't.
yes, ma'am.
Yes, we are together.
We started hearing it now.
Okay, so use clear and concise languages. Sometimes, you know, communication is very important. Communication, like I've always said. So even in the course of you document. Okay, so if you communicate with someone, it's like speaking another language. You are speaking another language with someone that doesn't understand, then communication is not effective. That's how it is. When you tell someone, I know sometimes maybe we have patients that when you have maybe one challenge or the other, you're in the hospital, and then the doctor is telling you are suffering from, give you some long medical terminologies, and you are lost, except it is explained. So that's what I'm trying to say. Even when we are documenting, or we are relating with those people, especially people that are not professionals, we should know how we go about it. You know, we should calm down and we should be explicit, explanatory. Whatever we say should be well explained. We should not give ambiguous statements that they will have to think and want to decipher. No, it should be something that is clear. They know, okay, he's unwell. Unwell how? What happened? What are the signs? What resulted in the unwell of you drawing the conclusion that is unwell? So you save yourself a whole lot of trouble when you are documenting by going straight to the point and actually stating it the way it is. Shortness of breath and maybe elevated heart rate. Maybe the heart was moving. All right. So that being said, let's see. Okay. So now we have types of documentation. We have different types of documentation. That is important that we note this, you know, because we are going to be on the field live. So we have to like learn these things. I know there's what we call learning on the job. Eventually, when you get the job, you are going to learn how to move around it, how to go about it. You are going to learn how to do it also there. But it's important that you already have the background knowledge. So when you get there, you know exactly what to do, and just with a little touch or something there, you are good to go. But the beautiful thing is that the curriculum is prepared in such a way that after this training, I tell you the truth, you will be able to, at least with the internship that you would have, which is the practical, that you actually have hands-on skills, build upon what you have already learned, then the sky will just be your stepping stone and starting point, and not. So we have the patient's care records. We have different types of documentation. You have the records where you document the care plans and the progress notes, chatting daily observations on a chart and interventions. Now, that kind of record is practically it's one of the, how do I put it? Is one of the records that a CACA must always have and keep. Why? Because you are the one that interfaces with this patient. I keep saying this thing over and over again. You are closer to the patient than even the doctor and even the nurse. Of course, we know doctors, when they come in, they check what they want to check. Before you know, they are gone, they move. How many doctors even actually take note of, maybe take into consideration the emotional aspect, or, okay, I'm going to break the sad news to the patient. How is the patient going to feel? Of course, if you had any relationship with a medical doctor, you understand that there's just no time for that side. So you are doing a whole lot of work, because you are taking the emotional aspect too into consideration, as well as you ensuring that the medications and everything. So your own documents is very important. Assessments, your observations, how is this person progressing? Maybe you see any signs, you report interventions things that have been nipping in the bud that could have been serious, but because of early detection, it's been like this. All these things are things that you need to document. Very important. That is going to be under the patient's care records. That's a different kind of record. Now we have the incident reports. Incident reports, those that are into safety will understand this. Now, when there is an incident, you have to give a report. An incident report is used to document unusual events or errors. Unusual events or maybe errors, reporting someone falling or a medication error. Remember the other day, yesterday, I guess, I talked about a patient that fell in my early years when I just, moved into the health setting, a patient that fell in the ward. Such thing is to be documented, because I was the first that actually saw the patient, and I needed to put it down to document. What did I see when I came? Where was the patient line? What did I do when I saw it? What was the follow-up? Did people come? The people that came, what did they do? And so on and so forth. That is how to document. I wouldn't just say, oh, an incident happened. I saw a patient falling off. A patient fell down, and I went there and I rescued the patient. Full stop. You've written reports, and that's a very poor report. That's a poor form of documentation, because it's not explanatory. The questions will definitely arise from this one, what I've just told you. Someone will ask, okay, when you saw that you rescued, how did you rescue? Did you call for help? Did you do this? Did you do that? So all these things will arise. So it's always better that when there is an incident, an unusual event, or maybe errors mistakenly, which mistakes are not really advised in the health system, because when you make mistakes, it can cost people's lives, so you cannot just afford to gamble to gamble with human beings' life. That is why we don't have to make mistakes as healthcare practitioners, because anything you do, I've had situations whereby there's a surgery and they say they forgot one thing, a pin or a towel or something inside someone's body. All those things. I have always asked myself, how can someone actually forget such things inside the body of a human being? It's very risky. So is used to document unusual events or errors. Like I said, the incident reports, reporting a fall or medication error. So there shouldn't be error. We should ensure that we've talked about medication management, one of those administration and management. We said, always look at the label, know the right person, know the time the person should take the injection or the medication. And if you follow through, you do your job judiciously, then certainly you are not going to have those issues. You won't have that guy if he's ready. Jesus. Okay, so now let's look at communication logs. Record important conversations with patients, with families, or other healthcare providers. Now, there are times you may need to interface with patients. with families of people that have maybe vulnerable, they have patients, So there are times you may need to interface with them. So when you have important conversations, maybe talking about their health or talking about their, health, yeah, their mental health aspects, or talking about maybe the emotional side of how you can help them to pull through, to move through a particular challenging period. So you need to make sure that it is recorded. It is important. This thing that I'm saying, it's very important. We are going to look at an illustration. So you see how important this thing is. You see that it has cost a lot of people their jobs. It has sent them home, due to just one mistake or the other. So we need to be extremely careful. Now we want to look at the best practices for documentation. What are the best practices? Use standardized forms laid down a procedure for documentation. Now, in any setting that you find yourself, like I like to say, most of us or some of us may wish to maybe get jobs, visa-sponsored jobs, or, we may wish to actually go and practice this profession in real life, because there are people that actually take this training. They just want to have the background knowledge and, to do what they can do in their own little corner. There are people that want to be professionals, like they want to actually go and practice it. So in every organization, in every country, they have their policies. They have the way they do things. They have standard in every organization, or maybe a hospital or a healthcare facility. They have the way they do things. That's policies. If something happens to someone, this is what we do. If this happens, this is what we do. So they have already standardized forms, methods with which you can write templates, documentation templates. So you getting there, you have to align yourselves with their ways of doing things. You have to align yourselves. Very, very important. Just as I tell people, even from the CV, if you want to apply for a job in UK, you want to apply for a job maybe in Australia or Austria. Now, there are different ways that your CV should be packaged. There's different ways that your CV should be packaged that will make you stand a chance. There are times people just get to see CVs and a lot of things are just jumbled up like that without arranging. That alone has put them off. They'll just see it at a glance that it appears this person is not serious, and just shift it because there are so many. So what am I trying to say? You follow policies, rules, you look at things and align with how they are. When you are in Rome, do as the Romans. So you align with how they are, how things are actually done, if it is done correctly. Yes, because in some countries, I don't want to mention the country, things can be done anyhow. So if I say when you are in Rome, do as the Romans, then it means that when you are in that place, you begin to do as is obtainable, then no. But in this case, it's important that we do the right thing and we get it right. Be objective. Like I said, record observations without personal opinions or assumptions. Record your observations. Maintain confidentiality. Yes, that reminds me, personal opinions or assumptions, many times we like to assume. We like to have a lot of assumptions. We assume a lot of things. We say, oh, I saw that person. It was like the person was, the picture you saw, you've already drawn your conclusion based on assumptions, based on your opinions, based on your biases. We talked about biases earlier. So I think the first today, if I'm not mistaken, of this training, biases. So sometimes naturally we have biases based on our cultural beliefs, based on our religious beliefs. We are just born with those biases and we grow up with them. So when we see certain things, it is important that we record our real observations. Do away with your opinions or what you think or don't think or your assumptions. Then maintain confidentiality. Ensure that patient information is kept private and secure. This brings me to what Mildred said yesterday, shared with us yesterday concerning the aspect of social media. Now in this age of social media, a whole lot of things happen. Someone could be in your care under your own care. per se, under your own care. You are trying to see how to take care of that person. And you see, you may never know in this media age of ours, you may never know what could happen. Someone who could just be there to snap that person's vulnerability, or maybe that person is not well, or snap that person in that state, or snap, maybe you are dealing with people that have mental health issues. Then you snap people, maybe in their vulnerable state with those issues, and decide to put it on social media and decide to do a whole lot of things. So this is very important. Any patient under your care, please ensure that you maintain confidentiality. Whatever information concerning that patient is with you there. Because as a caregiver, you will see a lot of things. So you see a whole lot of things. You see a lot of things. There are people you may not even know that they are. In the course of this training, I think I've had someone that said that up until she had to attend to a lady, she didn't know that she had to live as a caregiver with that lady. She didn't know that the lady was a lesbian, or, all those type of things. She didn't know until she had to leave. And because that is a patient, because that is that person, you are sworn to secrecy. You are sworn to ensuring that you are confidential. You keep their information highly confidential. Now, I want to see. Let's not leave. I can see we are 17 and then we are going. All right. Today, every day we do the trainings, we take attendance. And the Smart Solutions, we have our attendance. And on this platform, we always have a representative, one representative from BCC. So it's important that we try to ensure that we stay at intervals, especially when attendance is taken, so that it wouldn't count against you, because of course that won't be Dr. Mrs. Dorothy's fault. I'm going to be exonerated from that. So please, for us, let's just, what is worth doing is worth doing well. And I thank those that have been patient, and those that I owe stars, really, I still owe them stars, very beautiful stars. So use approved abbreviations. The use of approved abbreviations. Avoid confusion by using only standard abbreviations recognized by the healthcare facilities. Avoid confusion. Use only the ones that are recognized by the facility, because there are a whole lot of abbreviations that can be used, but restrict yourselves to the ones that are used in that facility, that are commonly used within the health sector, and above all, within the policies and within the facility that you actually work. We have a lot of healthcare facilities, that people work with their own different policies, like I said earlier. Now, double check entries too. Double check entries. That's very, very important. Double check entries and be sure of what you have actually entered. Important. Okay, we're almost there. Just have 2 slides to go before we switch over to the practicals. Now, let's look at the very last one, the legal and ethical considerations of these things. There is a legal aspect to this work we do. Thank God we are highly learned people on this platform. So you understand that the law has a very heavy sledgehammer, very heavy one, especially on health workers. Any little thing can put you in a state that that you've not dreamt of before. It can just put you there due to just one act of negligence or act of carelessness or something. So there are legal implications. Poor documentation can lead to legal issues, can lead to very, very serious legal issues. You understand? So when we are documenting, we should ensure that we do it right. Very, very important. We do it right at all times. Because if you don't do it right, it can get you the way where you are not, get you, I don't know how to even explain. It can take you to somewhere that you don't really envisage or visualize that it can ever happen to you. So it's important. Now, ethical responsibilities to maintain patients' confidentiality and integrity in documentation is paramount. Do not, I've seen situations whereby in order to exonerate a particular facility, health workers are actually made to do some unethical practices, to do some things that is not ethical, yes, to try to say, okay, change the narrative in order to suit the facility so that the facility, they will not get into trouble, and let it be like this. If we tell them that this thing was actually like this, it's going to create this problem, it's going to create that problem. So it is very important that we have a high level of integrity as healthcare workers. Very, very important. So when we are documenting, please make sure you do the truth and nothing but the truth to save your integrity. You understand? To keep your integrity. And in doing that, also, do not forget to maintain the patient's confidentiality. Very important. Okay. All right. So now we are just going to look at two scenarios before we wrap it up. We are going to look at two scenarios, checking patients' vital signs documentation. Now, I want you to understand the difference. I took time to bring this out. I want you to understand the difference between a poor documentation and a good documentation, accurate documentation. There is a difference, though I have said it in the passing, but I want us to see it, how we should document, how it is important for us to document. Now, this is accurate reporting or documentation. We have a healthcare assistant checks the vital signs of a patient recovering from surgery. Now, under the observation, what does the healthcare assistant do? He or she takes the patient's vital signs and notes them in the patient's chart. Remember, we talked about charts earlier. Notes the vital signs in the patient chart, like you can see here. The date, 3rd October, the time, vital signs, the blood pressure, this is the blood pressure, the heart rate, this is the heart rate, the temperature, and you see detailed analysis to show that, yes, that person, you actually did your job well, you actually did all those things well. Now, what is the comment at the end of the day? The patient is alert and oriented. No signs of distress. Vital signs within normal limits. You have finished your job. Now, this is what you did. And having done it, this is your comment after you did it. This is a perfect documentation, accurate. On every documentation, there is something that is not here, that is not on this particular place that I had said. I purposefully did not put it so that I will find out whether we actually have been following what I have said, because I have in the passing, even though we didn't get to documentation, I know I have said something about that. Or in our normal daily life, when we document a thing, what is that thing that should be that is not here? I would need to hear it. But before I hear it, let's look at another scenario. We've talked about the first one where everything detailed, blood pressure, the heart rate, the temperature, everything is detailed. Now we are going to the next one, poor reporting, documentation. The scenario, the same healthcare assistant documents the vital signs, but does it so poorly. You can see from there the dates, yes. Vital signs, the patient seems fine. He or she has finished taking the rates without even documenting the rates, the figures, against the vital signs that he or she checked. He just assumed that, okay, is 120/80, okay, it's normal, it's fine, is this okay? My conclusion, the patient seems fine. Everything looks good. This is a poor documentation. So the A to Z of this is just for us to understand that when we are documenting, we have to have the detailed analysis of it so that anyone that checks it will really understand what to do. Now, why is the other one considered accurate? This one, the first one I did, why is it considered accurate? Because all relevant information is documented. The healthcare assistant records observations without personal opinions, just records how it is. And the entry was made shortly after taking the vital signs. But the other one, what happened? Vital signs not listed. That's the first wrong thing this person did on this documentation. Vital signs not listed, making it impossible to assess the patient's condition. Now, phrases like seems fine and everything looks good, lacks measurable data. It cannot be measured. How good does it look? On what basis do you derive this conclusion? It's pregnant. Those statements are pregnant. Nobody can really know what is contained in the statement, except it comes out or except it is explained. You understand? So, also, the documentation does not provide specific information regarding the person's health status. You remember when you document, you are passing it over to higher people that are higher in the profession, maybe the doctor, maybe the nurse that will go and analyze what you have done. Use that based on your own feedbacks. They will now be able to know what exactly to do with the patient or how far to continue with the care that they have been giving the patient, what to do or what not to do. So if it is this pregnant or this ambiguous, it's not explanatory. So as such, the doctor will not be able to follow up. So it is important that we do this and we do it right. So aside that, I want to ask before just 5 minutes, exactly 6, we would have to turn over to the other side. Now, I want to just give you just a short illustration. But before I do that, I want to ask, what is missing from this report that I have written? What's actually missing, or what's missing from the report that is not here is what I want.
Good afternoon.
Yes, good afternoon. Good afternoon.
Yes, this is Omawumi, Mrs.
Okay,
Omawumi Adeshore.
Okay,
yes.
Omawumi.
While I see sorry ma, in what is missing in this poor reporting or the other one?
What is missing? Excuse me,
Is it in this poor reporting or the other one?
No, I'm saying that something is missing on the 2 reports. I purposefully did not include it.
Okay, what I think is missing, ma, is weight.
Okay, the weights. All right. That's fine, but that's not actually what is missing, because weight is a secondary, I don't know, is a secondary, okay, let me not take you into that because that's for real medical people. But weight is not what is missing. I mean, at the end of the report, something should have been done that is not there. So I want to see who can tell me what that is. On the 2 reports, I did not put it. I just deleted it out because I wanted to ask this question at the tail end of this training. Let me see. So there's actually something that is not here. That is not here. Now someone can tell me.
Is it at the end of the report?
Correct.
At the end of the report?
Yes, at the end of the report.
At the end for the 2?
Yes, at the end.
At the end, when you are closing your report, are you hearing me?
I am with you, yes.
You need to write your name, maybe reporting nurse, and you sign, then your name.
Wow. Okay, thank you. That means you need a double star. It's like you were one of those I promised star that stayed with me to the end. So now it means it's double star. So I will make you a double star general.
Thank you.
Thank you.
Yes,
Yes, that's just it. That's just it. Anything you write, that's why I say it doesn't even have to be in documentation in the health. Anything you write has to come with a signature. Any official thing you write has to come with a signature, especially if it is on paper. And even if it's not on paper, your name has to follow it. Your name has to be there. And the ones that you actually write, handwritten ones, has to come with your signature, because your signature is your identity. Your signature is your stamp that tells anybody that, yes, you did this. Because I can type anything and send to you, if not in this era of mails, that someone will say, okay. But come to think of it, let's look at the traditional way now. Maybe you write something, I write something now, and I send it over to maybe gifts. And I can tell when it gets to a problematic place, when it gets to a place whereby there are issues that erupt from that writing. I know handwriting can be detected, but of course, if I want to put gifts into trouble, I can write something. I can write and try not to write in my own handwriting. That is very common. I can write it and submit it because I want to put gifts in trouble. You understand? And when it boomerangs, when there is problem, I deny that I'm not the one that wrote it. But anything you write and append your signature, anything you write with your name and your signature, especially in the health setting, Oh, you have to be sure of its authenticity and of the facts, of its truthfulness. Because if anything happens, it has happened, it has caused a whole lot of people issues. It has caused. So thank you so much for answering that question. Who actually answered that, my question? I'm trying to.
Amos Modupe.
Okay, thank you.
You log me out. I don't do this thing now, but don't do this thing.
Sorry, what's happening? Helen, are you here? Helen?
The network is terrible. It's frustrating me, I must say.
That's what I'm trying. I'm just
telling you.
It's I don't know why.
I'll be moving from here to swap my SIM, going from one place to the other. I just left my house now. I'm in the shop now to see if I can get network.
Try.
As I talk to you now, I'm not even in the house now. I have to leave my house.
That's sad. That's why I said that if we are doing the normal one and network is doing like this, then when we get to the practicals, please be handy to change to the network that suits you better. Maybe, I don't know, if you have another line or something, because we need network very soon, shortly. I'm just going through my phone because I tried to look to see how to help anybody that is stuck. I have seen, Susan, are you here? Okay. Hello, Susan, are you with us? Okay. All right. And Mr. Kinlade Benga, Mr. Benga, are you here? Okay. We just have to do what we have to do because I don't know why network is doing this to us. I just pray that it does well because we have to move to the practical. So practically, without wasting our time, I just wanted to share with us one incident before we move over to what we have the other side for the practicals. Now, there is a scenario, inaccurate documentation leading to a patient's harm, like I've already said now. There's a nurse, a registered nurse, Emily is her name, responsible for documenting patients' assessments and medication administration in a busy hospital. Now, during a particular hectic shift, she mistakenly documents that a patient received a critical medication when in fact it was never administered. Now, what are the consequences of that? The patient suffers a severe reaction due to the lack of that particular medication that she documented that she had already given, requiring emergency intervention. Now, an internal investigation was carried out that revealed that Emily's documentation was not correct. It was error. There was error in her documentation, highlighting that she failed to follow proper protocols for medication administration and the documentation. Excuse me. So as a result of that, what happened? She lost her job due to negligence and the serious consequences of her actions. Emily was actually terminated for failing to provide safe patient care and for unethical documentation practices. So that's just one of the scenarios that we get to face, that we get to have. It's very, very bad. So that having said, I don't know if we have any question or any contributions to make, because we would now have to move to over to the practicals, to the CPR practicals that we have for today. So I don't know what we can do concerning the people that have the network challenge. It's actually sad. I don't know how we can go about today of all this. Okay, so look, please, do you have any question?
I have a contribution.
Okay, contribution. Thank you, Mildred. Go ahead.
Good evening, house. Doug, what you just said, what you just said now, I've seen, I've witnessed it like three different times. There's a woman in the UK actually. So I went to visit my auntie then. It happens to be my auntie's neighbor. So she just cried. She was crying and crying and came knocking my auntie's door. banging. She came in and said, just exactly what you just explained about proper documentation and recording of patients after treating the patient or giving the patient medication and all that. What happened was she attended to a patient before she closed that she did not record, put a proper documentation for the person that she handed over to. So the drugs that she gave to that patient, the person that took over from her, that she handed over to, look at the patient's file and now discover that those drugs, to her, those drugs were not administered. So she now went and gave those drugs, and the patient, that became an overdose, and eventually the patient went into coma.
Jesus.
So, yes, yeah. So she was crying and said she was going to lose her license. She was going to that the board they are going to set up a panel for her. That in that panel that she would lose her job. But we had to intervene with prayers. Called in a pastor, Nigerians now. What we do?
That's
what we do.
How to do best.
So
yes.
I actually called a pastor, my pastor in Nigeria. I was there. So I had to call my pastor. We now started praying for her. We fasted, me and my auntie and her, we did fasting. So to the glory of God, the woman that went into coma, she's an elderly woman, came back to life.
Wow.
Very, very healthy.
Wow.
That was what saved her job.
Wow.
Because that day she was crying. She was talking about her mortgage, that she will not see money to pay again. She will lose her job. Her mortgage will go. That in fact, at the end of the day, she will come back to Nigeria empty-handed. So that was what saved the situation. Then yesterday I saw on TikTok, somebody also lost her job, a healthcare administrator. Yes, because she comes late every day, and they've been warning her that she shouldn't come late again. Unfortunately, she came late. The patient that she was supposed to take care of, the woman fell from the bed before she arrived. That was how she lost her job. I saw the video yesterday on TikTok, yes. And it's one of those that went off with these care workers, this thing. So they said they're going to bring her back to Nigeria. Yeah, she's going to leave the country. So we have to be very careful. Thank you, ma'am.
Thank you, Mildred.
Thank you. Thank you.
Filled with lots of experiences. I think it's high time you think of writing a book or coming or doing something with these experiences that you have had. Anyway, thank you, Mildred. That's a beautiful one. So that's just further to make us understand as care workers, like I said, that we have to be seriously and extremely careful in anything that we are doing because we are dealing with human life. There is nothing as important, there is nothing as valuable as human life. So when we are dealing with a human being, we should be on top of our game. This is something that we can't even talk about it too much. So just like that lady that you said, if God was not on her side, having after the meditations and all that, God said it wasn't yet time for her to cross over. That's why. Imagine what would have happened. So it's important that we try to be careful. I cannot overemphasize this. When we get to the legal and ethical issues, I think we still have one more module that talks about the legal aspects of it. When we get there, you would understand better what I am saying. Many people have lost their jobs. In fact, it's easier if you just want to be a care, maybe a CHCA, that you don't want to be a professional one. You just want to render the health services maybe to your family, to your neighbors, and just around unpaid work. It's easier. But when you have to cross over to places like maybe UK, places like maybe US and Canada, you want to actually go. Different countries have their policies. And of course, you know that in Nigeria, anything goes, anything happens. But over there, not everything goes. Not everything.
Madam Dorothy, I have a question.
Yes, please.
Why is it that they don't allow like prayers, like in the UK, hospitals, they hardly allow people to come in to pray for patients? Is it that they don't want them to get well on time? Or I don't understand.
Okay. You're a very funny
I
person,
want,
Mildred. You are very funny.
I
Okay.
want to, I
Yeah,
want to
it
know.
is.
I know you know better.
Yes, it is true. Even though I I have seen maybe one or two places that, despite the stringent measures they have, I have seen one or two places that actually do pray, but it is against the policies of that particular place that you have just talked about, the UK. The reason is this: it is not as if they don't want the people to get well, but there's what they call cultural and religious diversity. Okay, what I mean by that is there are different religions. It's not like in Nigeria here, you know, like just as you said, they pray for that woman. Our own is prayer, prayer, prayer. And, you know, there we have people that would not actually want that prayer. For instance, let me give you an example. I'm going to explain it further. Some time ago, I said it in one of my trainings that I saw on Facebook of a lady that lost her job, a care worker that lost her job. Why? She lost her job just because she prayed. That's all. She didn't commit any offense. She was not, it wasn't it wasn't any serious thing. But she was a geriatric caregiver in the aspects where they take care of the elderly ones, hospice care, good. So she was there with those people that have maybe some years countdown to go. So she walked in this fateful morning and she prayed for her patients, you know, because of the love, because of the connection, because of empathy and everything. There are people that are very emotional. So the woman was 80-something years, you know. So when she went there that day, she prayed for the lady. And then she left. After praying, she left. As soon as she left, it didn't take long. The lady's daughter came to visit the mother in that care home. And when she came, you know, the mother, being excited, and I was like, oh, do you know the lady, you know, mentioned her name, came around, and she prayed for me today. I feel so much better. And the daughter just nodded her head. She smiled, and she didn't utter any word. The next thing the daughter did was to go straight to the hospital, to the administration of the hospital, went straight and reported to them. And this is what the caregiver that who asked her to pray for the mother, just that. Who asked her to pray for the mother? Why? Because they have different religious beliefs. So you cannot say we should just generalize and say, okay, somebody is sick, let the whole hospital, let's gather, let's have fellowship, you know, like we do in this part of the world. No, that side, they are very careful about that because they are Muslims, they are Buddhists, they are traditionalists, there are a whole lot of people mixed together. So it is important that we take the traditional, the religious aspect out of it so that we don't step on certain toes. Of course, we all believe our own religion is better. You understand? So when it comes to that, that is the major reason why prayer is not. It's not like in Nigeria. That side, prayer is well with us. So Mildred, that is just the reason. And again, something I remember based on this thing you have said, connection and knowing your patients is very important. It's paramount. When you know your patients, you will be able to connect. You'll be able to know what is the tradition. What do they believe in? Are they Muslims? Do they believe in God? You know your limits, and you know you cannot exceed your limits. That's very, very important. So in UK, not only in UK, even US as well, all this prayer thing. So if you're in Nigeria, like those of us that are mostly Nigerians, you know, you decide to go over there, you keep your prayer in your pocket and you pray in your house. If you want to pray for any of your patients, you pray for them in your house. You pray for them very well in your house before you eventually move over to attend to the patient. So that is it, because of the religious beliefs of people, diversity in the religious beliefs. So in order to be on the safe side, in UK especially, you hold your own prayer because you have your own beliefs, your own religion. The person you are praying for, what makes you think that that person aligns with your faith? So hence, these are some of the reasons that it's not actually accepted in most of those care homes and hospitals. Thank you, Mildred.
Thank you, ma.
You're welcome. So, are we good? All right. So right now, we are going to start take. I beg you today, we will not follow the traditional way of taking our break at that 6 something that we used to do. Today, we may wish to, as network will lead us, we may wish to keep moving. And then at any point that we see that we like, we can take a break. Let me say so. And we may not even take a break at the end of the day. Depends on how it works. So to help us have this hitch-free process, please, I crave your indulgence. Now, your mics should be muted. Mute your mics. If you don't mute your mic, it's technology we are dealing with now. If you don't mute your mic, you will not be able to see clearly the visual quality of what we are going to do, and it will disrupt your network. So the first thing for us to do is, please, let us mute our mics, because anybody's mic that is on mute, that is not muted, would disrupt the entire network. That's what happens. So please, bear with me.
Okay, ma'am.
As we do, just give us a few minutes, few seconds we are good to go.
But ma'am, not saying anything. I don't know if from my own
hold on, please. It's a progress.
My
Okay, please, hold on, please. You're not going to see anything. You're not seeing. It's fine. Just hold on. Let's try to put it to a few seconds. We'll be done with it.
Okay.
Okay, so can I go? Okay, so like I had told you earlier, today we are going to have the first 8 aspects of it. So I'm going to be working with some professionals in the field. I'm not going to be working alone. You know, all along you've been hearing just my voice. I've been the one talking. But today we are going to hear some voices. We have the media. We have our own officer, Officer Wilson, is one that is going to take us through. He's a member of International Red Cross. He is, when you talk about first aid, he's well-grounded. He's well-grounded, and he's here to just give you everything you need. So that's Officer Wilson. He's part of my team. And we also have our very beautiful lady, Officer Mary. She's here too. She is a Red Crosser from International Red Cross, and she's going to be helping you to get whatever we want to get at the end of the day. Okay, we also have the media guy, which is behind the scene. He's right now behind the scene, so you wouldn't want you to see his face yet. Maybe when we are done, I'll let you see his face. So we also have our own casualty that we are going to be using, Officer. We don't want them to see the casual so that they don't see him become a casual. So you are also going to see Officer Ubong. He's also a member of Nigerian Red Cross too. So we are going to give you everything you need to know concerning first aid. So at this point, over to Officer Wilson. Please, you can pause like we do during our practicals. You can pause and ask any question at any time. You can just unmute because your mics are muted, so you can unmute and ask any question and give you a chance to do that. We welcome interactions, we welcome opinions, we welcome suggestions as we start. So over to you, Officer. So please, can everybody hear me? We need to know because this is technology. We have to be sure that everyone can hear. Are we together?
Yes, ma'am.
Yes, ma'am. Yeah, but the video is not really showing. It's hanging here. Yes, even here, the video is very bad here too. It's not clear at all.
All right, good evening, everyone. Good evening, everyone. Can you hear me?
Good evening, sir.
The video is on slow motion.
We can hear, but we can't see clearly.
My name is Zun, and I am here to share some first aid experience with you. And all we really gonna do now is take practicals. We show some things that you need to know, things you need to do, and some things you don't need to do as far as first aid is concerned. We will not bother going into talking now, digging into the history and all that. We've already heard all that. So now we want to share what we need to know about first aid. The very first thing I would love us to look at is your first aid box, your first aid kits. You know, before you do a successful first aid, before you are successful first aid.
Sir Wilson, I need to be sure if they can actually see. Please, what's the situation now? If your mic is muted, it's easier for you to see. So that's why I said the first thing is let's mute our mics. What's the situation now as per the quality, the picture quality?
Very bad, ma.
Very bad.
Very slow. No, it's not moving the way it is expected.
On my end, I think it's okay.
Okay. So is it a general opinion? Is it from everybody? Because if where you are, if your network is actually bad, then it's going to affect the picture quality there. I need to hear. Is there anybody that can actually see? At least one person? Is there anyone?
Yes, I can see very
we
well.
can see.
I
can see very well.
Clearly, very well.
Okay, that's what I'm saying. It's just that we have network.
It's better now.
Okay, thank you. I need us to see. Because if they don't see, the purpose is defeated. Go ahead, officer.
All right. Like I was saying, the first thing I want to share with you is the first aid box. The first aid kit. Sometimes you have first aid kit back. They come in different sizes, different qualities, and these are things that can actually help you to do first aid. I have my first aid box here. My first aid box well loaded, and I have them here. And meanwhile, if I may ask, at least 3 of us or 4 of us, can we share together? What do you know can be found in the first aid box, please? Things you know we can have in the first aid box.
I know there is cotton wool, there's plaster.
Yeah. Plaster.
Yes,
Cotton wool.
What?
Then bandage.
Bandage.
And they have this.
All right.
What you check the head and the heart.
All right. In cotton wool, as you mentioned, cotton wool as one of the contents of the first aid box. Mark with X for me. Just mark X. I'm coming to that. You mentioned, if you mention something like methylated spirit, also mark X. I'm coming to that. Okay? Are we together?
Yes, sir.
Yes, sir.
Please, some people should mute their mic. Let's see the picture
If
clearly.
your mic is on, even one person, it alters the picture quality. That's how it is. So please,
all right.
let's try.
Also, some people may mention things like TCP. Still mark them X for me. I'm going to tell you why I say we should mark them X. Before now, actually, everybody knew things like that as disinfectant, cleaning of wounds, and they were one of the best companions for first aid. But you know why we keep changing things in first aid, keep reviewing them from time to time, is due to medical changes in medical science. So the methylated spirit, the what do we call it, the TCP, and all those disinfectants, they are not usable anymore on fresh wound. They are used in old wounds. But instead of them, because someone might ask, if you want to clean the wound, what do you use to clean the wound? What you use to clean the wound is clean water. Are we together? We use clean water these days, not the disinfectant. Disinfectant is used for old wounds. I come now to cotton wool. Cotton wool is not used on the wound.
Power off.
Because if the wound is and it gets into the wound, before you remove it, it will cause bleeding. Are we together? So now, all you use to cover the wound is bandage. So I want to share with us the contents of the first aid box. Here in my first aid box, please permit me, as I just carry the thing, I show you. Here I have the plaster. This one is familiar. Okay, we all know this. This is the plaster that we use to cover wounds. Okay. The second thing here, as I touch them, I show to you. This one is a padding made out of a bandage. A pad. Actually, by the time we want to treat severe blood loss, you see the use of this because this is what we use to cover the wound, to control bleeding. All right. The next thing I have here is the splint, actually used for fracture, immobilize fracture. And it goes in line with a bandage. And what I have here is called the triangular bandage. Now, let me talk about this bandage. The triangular bandage here is called the first aid companion. You now, as a first aider, this is your companion. Why is the triangular bandage the first aid companion or the first aider's companion? Because you can do a whole lot of things with the triangular bandage. Everything that any bandage could do can be done with the triangular bandage. You use it for elevation sling, use it for arm sling, everything that you need bandage to do, this can do for you. If you can use the triangular bandage as a scarf. You can use it as a scarf, the way I'm using it now. Okay? Now, you can use it to cover a wound or burns. Just cover anything you want to cover. You can use the triangular bandage as a fan. Okay. Can you see that? It can be used as a fan. Now, if I bring triangular bandage, if I fold it, the first fold, if I pick the apex here and fold it to the base, it gives me a broad fold bandage. And this broad fold bandage can be used as a girdle. Can we see it? Please, let me be sure that we are together.
Yes,
Thank
thank
you.
you.
You can see it.
Okay. Okay, so it can be used as a girdle, like I'm demonstrating here. Now, if I fold it again, if I take the next apex to the base again, it still gives me another broad fold bandage. This can be used for head injury. Okay? This broad fold bandage again, even this can still be used as a girdle. We can also use it for arm slings. Okay? Now, if we go back again and bring the apex again, we now have a narrow fold bandage. And this narrow fold bandage now can be used as a roller bandage. We can now use this for mobilize injury at the risk discount. Okay? Okay, now every finishing with the triangular bandage ends with a reef knot. Right to left, left to right. Then you can tuck it in. Okay? Now, we can actually use it as a wrap. That is. In case you want to mobilize an injury that have foreign bodies inside the injury, for instance, a head injury with broken glasses inside the head. With this now, you can place on the injury site, then use another bandage to hold it. Why? So that the tie that you would do will not inflict pain on the casualty. Remember, in first aid is aimed at minimizing the pains. We are trying to alleviate human suffering anywhere it may be found. Sorry? All right. All right. Now, with the triangular bandage here, like I told you, do everything a face aider wants to do with it. So that is the reason why it is called the first aid companion. The next thing I have in my first aid box here is the plaster. We all are familiar with this, and we know what it is used for. We have a scissor here, and this is a faucet. Okay, you can actually use this and pinch a cotton the way I am using to clean a wound. This is the roller bandage. And this roller bandage is a broad fold. Use of the triangular bandage. And this is a narrow fold bandage. A narrow fold bandage. Another thing that is here in my first aid box. Are we together?
Yes, sir.
All right.
Another
thing that is in my first aid box is the emergency blanket. This is emergency blanket. Everything that the blanket could do can be done with this emergency blanket. Okay, that is an emergency blanket. With this, you can lay the casualty down anyway, anyhow you want to do it. Or you can also use it to cover the casualty if need be. This is an emergency blanket, and this is how it comes. That is the pack. That's how it is sealed. But when you open it, it will give you this. Okay. There is a big heat spray here. This one is good for sport. There is a nose mask here. And also, of course, safety pin is here. This is the gloves. The sterile gloves. You have to use the gloves each time you want to do first aid. Most especially when you are dealing with severe blood loss. The reason why you have to use these gloves is to limit the risk of cross infection. These are the gloves. And of course, I have here with me the resuscitation mask. This is used for rescue breath. For artificial ventilation or artificial respiration, or you call it the kiss of life. That is the resuscitation mask. All right. The next thing I want to show you is another splint. This splint is a professional one. This is a professional splint. You can actually pull it any way you want it, anyhow you want it. This is used to immobilize fracture. It is now used just as you will use these other splints. Just look at this. I have now brought it to narrow foot. Depending on the purpose you want to use it, I can now use this on the leg. Okay. I can turn it again.
Recording in progress.
Now, assuming that this lady is having a fracture here at the hand, then I want to mobilize it with a splint. With this, you have mobilized fracture. It does the same work the other splint does, and even better. All right. So that now we conclude about the first aid box. These are things that you need to have, things that you need to know their uses, what they are used for, and you have them. It will help you. There are some first aid kit bags in the pharmaceutical shops. You can just get in, pick one. All those things are there. All right.
Okay. Thank you, officer. I don't know why they are. I'm not seeing some of their comments, so I need to find out. Hello, everybody. Are we together?
Yes, mommy.
Can everyone hear me?
Yes,
I have seen it. I don't know. Is there anybody that can really or has really seen what the application is here? Because if we are not able to see it, the purpose is defeated, really, that we are here, and I will be so happy. So, what are the feedback? How many people can see it clearly? I just need to do that. Maybe I can try to do something, change the network or something.
I can see
is it
clearly.
clear?
The problem starts when they unmute their mic. If everybody can mute their mic, it will be okay.
Yes, I think so too.
When it tries to get well, once they unmute their mic, it will take long before it's balanced. So everybody should try and mute their mic without somebody reminding them, especially that person that is using Infinite Note 7.
Yes, that person should mute his mic.
Exactly.
In fact, that person should mute permanently. You can't be complaining for poor quality of video why you cannot mute your mic.
So that's when you want to ask question or talk. That is when you unmute now.
We've had to do this over and over again, and I've seen a couple of comments, hence I decided to post it. So please, I crave everybody's indulgence. Please, let's mute our mics so that we can get it. You know, we still have 2 days practical, so if we don't get it right today, when we are actually doing the clinical aspect of it, which will be Wednesday and Thursday next week, I wouldn't want us to have all this issue. So please, let's mute our mics. For network, we are using a 5G router, so it's not something that will fluctuate network. So if you mute your mics, we have used it before and it's tested and trusted, please, so we can be on the same page. Please, I crave all your indulgences. So, officer, are you done with the first aid?
Yeah, I'm done with the
we should have
first aid
proceeded
box.
to the next.
Yeah, let's proceed to some other thing.
Do we have to change the network?
In 3 minutes.
Okay, so please, let's give it a try because we are using an Airtel 5G router. Let's see if we can swap to MTN. So just give us 1 second, but I will need to know the difference. If MTN is better with those people that are talking, well, let's see how we can do that. So please, just a few minutes to the changes.
Hello?
Please, what is happening? Oh, is it my network or what? Because I can't see the Dr. Eke.
We are seeing Infinite Note 6. If that person have not muted his mic or her mic, you will not see Dr. Dorothy.
No, they said they said they are trying to change the network. They want to switch to MTN. So we should give them some minutes, please. Dr. Dorothy said they want to change the network. They want to switch to another network.
This one, not my side, from that side. No, Nana. The network, is it everywhere? I've been on my side alone.
Okay, can you
We
hear
can't see
me? Hello,
anything yet today.
can you hear me?
Yes, ma'am.
Yes,
Yes.
Yes,
Today is
ma'am. Yes, ma'am, we can hear you.
for practicals. Okay, so I was saying that I just had to change the device so that we can see if MTN would be better. I have actually done everything that we need to do. So let's mute our mics and see how we can have the rest each week. I pray we are able to, because the idea was CPR today and then we do the other clinical aspects. So if network is okay.
Anybody?
The network is just. The network is.
Recording in progress.
Okay. We are going to move now to the next, what we have. I don't know what's happening.
I think we have to continue with the Airtel. It's better like that.
Okay. Is it clear? Can we see?
We can't see anything, and it's really breaking.
Okay, I need
No, ma, I can't see anything.
It's blank now. Can't see it.
I'm seeing Infinix Hot 6.
Dr. Dorothy, I think the other network is better. It was very clear.
Yes. This is worse.
Which one are we actually? I was thinking this one would be better.
Because the other one was very, very clear, ma.
Okay,
It
so
was clear.
Wow,
It
this one is
only
good.
Yes, it
gets
was
bad
clear.
when somebody unmutes.
okay.
We should go back to Airtel.
So should we get back to Airtel? Is that what we are saying? Should we get back to
No,
the
don't
Airtel?
worry. This one is clear.
Okay, I can see it's clear, yeah.
Hey, voila.
Okay, it has come up, eh? It's okay. It's the same thing. It's okay. Let's continue with this, man. Since it's already
Okay,
on.
let's don't worry, we'll have the videos. I don't know. Today is not just I don't know where we're having this.
No, it's good.
I think
Doc is good. This one is clear
okay.
too. You know, all of us are not using the same network. Some are using MTN, some are using
Please, let's
mobile. So it
allow the
can't be.
video to show. Let's stop talking so that
This
we
one
can
is clear.
see.
Please, let's use this one.
All right, please, officer, you are good to go. I think you can speak out and let's go.
What I want to share with us now is what we call the triage. Triage is a process of quickly assessing multiple casualty incidents, giving priority for treatment according to severity of the injury. You can imagine a scene of accident, then you see 4 people on the ground, and one has bone issue, one has a bone issue, the other is bleeding, and the other is just dumbfounded. So mute, cannot talk, cannot do anything. So there is a principle of the principle of 4 B's. If you put 4 B's in a vertical order, the first B is the casualty with a breathing problem, which is the most life-threatening among all these. The second B is bleeding, which severe blood loss can cause shock and lead to unconsciousness. The third one is the bones and bone, the last. So now, on getting to see the casualty that is not talking, like the one, like this casualty I'm having here, I'm taking him to be that casualty. As you come in to check this casualty, that is when the doctor A, B, C, D that you were taught in the theory comes up. So now, this poses like a danger, and this is my D. I am taking the danger away from the casualty, making sure that where I am going to assess or do my survey on the casualty is safe for the casualty and for me as the first aider. Then the next thing that I will check, I will now check for response. Hold the shoulder, shake him gently. Are you all right? Are you okay? If the casualty is conscious and alert, you will answer me. But if he is not answering me, I will go ahead to the response, which is the R in the Dr. ABC. I've checked now for response and he's not responding. The next thing I want to check now is breathing. For breathing, please, are we together? Breathing, you use your jaw and get it closer to the casualty's nose, while your eyes should be on the diaphragm to check the upward and downward movement of the chest, which indicates that the casualty is breathing. If he is not breathing, the next thing you do is you check for circulation, which is the C in your Dr. ABC. And to check for circulation, there are points in our body where we have the pressure points. And where we have the pressure point is where we have the arteries. And where we have the arteries and the pressure point, these are where pulse can be felt in the body. We have 22 of them in the human body. If you divide the human body into 2 vertical planes, you have 11 on each side. But for the purpose of phase A, 4 of these points are very key. The first point I want to show us now is the carotid pulse. It is found at the neck. Now, I will now check the carotid pulse. Please, I will want all of us. My hand on my Adam apple. Slide a little. You can feel your pulse. How many of us can feel it?
Clear.
All right. Now, the next point you can feel the pulse is under the arm, where we have the brachial pulse. Then the third one is the wrist, where you have the radial pulse. With the tip of your finger, or of your index finger, just place it on the wrist here. You can feel radial pulse. And the next point is the cerebral pulse by the femur. So now that is how we check for circulation. We want to check and you feel pulse. What we call the internal compression. Now we are in the that has to do before that. You have to conduct what we call the primary survey, which is the blueprint. And what is the blueprint? The blueprint is the head to toe check of the casualty. In blueprint, from the head, you massage the casualty, open the eyes and check, look at the casualty's nose, and also open the casualty's mouth to see if there is foreign object. And if there is one, you remove. Because if there is any foreign object in the mouth, that is what blocks the airways and makes the casualty not to be able to breathe. Now, another thing I want to tell us is, you may check and see pulse, but the casualty is not breathing. Then there must have been something wrong with the airways. That is when you have to check the mouth to make sure if there is any foreign object in the mouth, you remove that as blood. And now, when you remove that and give this casualty external chest compression, it will come up. And when once it comes up, the next thing you do is you place the casualty in the recovery position. Now, for recovery position, this casualty is wearing some things in his hand. You will have to remove them. And keep them safe. Then you now take the hand nearer to you and put it at right angle. Hold the other hand, place it under the jaw. While putting the casualty in the recovery position, make sure the airway is maintained. Now you go for the farthest leg. Make sure you check his pockets if there are any sharp objects like key or any other objects. If there is none, like this one, there's none. You go to the farthest leg bring the leg and the other knee. Then you pull him tight. Now, this other right angle to act as support. The casualty in the recovery position. That is the casualty in the recovery position. As you can see, the head is tilted forward so that the casualty is on its side. This is the lateral position where casualty is being put when recovering from pulmonary resuscitation.
Okay, thank you, officer. Thank you. Thank you so much for that. Thank you. Our casualty. All right. I want to first of all find out if they were able to see that, because recovery position is very important. Like I have told you, we are going to have to carry out a practical. We will have to do maybe a video of 3 to 5 minutes on any skill that you have learned. Anyone you feel most comfortable with. That is what is required of you. That's part of your assessment. That's how it is done. So, recovery position is very, very important. You need to know how a person is kept in a recovery position after an unconscious state. By the time the person is getting better, you have to place the person in that position in his or her way to recover. So I want to believe that we're all able to see that. Please, I need feedback so that I will know that we are actually not busy doing nothing. So how many people got to see that? Please saw the recovery position, what to do? Please, I need to hear your responses.
I can see very well, Dr. Dorothy.
I saw the recovery position.
It was very clear.
So I want to believe that only 2 people
Yes, the recovery position was very clear.
Okay, thank you. I'm happy about that. So we are just going to see how far we can go. I don't intend to take your time more than 8 o'clock, regardless of whatever. So let's see how we go. Because next week we have clinical duties, the actual vital signs and other things. So go ahead, officer. Thank you.
All right. Now, that recovery position we've just is done when the casualty is recovering from cardiopulmonary resuscitation. In cardiopulmonary resuscitation, you have heard they say C there is the cardio is for the heart, pulmonary is for the lungs, while resuscitation simply means to restart or to bring back to life. To do the CPR, this can actually be done with an AED machine, if we have it. But in the absence of AED, we do CPR. What I have in my hand is the resuscitation mask. And this is used to give the kiss of life. How do you apply it? With this, you put in the casualty's mouth. Okay? Then you now make a seal
I'm not seeing the video, you know.
Okay, you can see now. Yes, I'm seeing it from where I am.
All right. You make a seal with the nose and the mouth to tighten it well. Then give 2 rescue breaths. And to give the 2 rescue breaths, you take in enough breath in you before you pump in. While giving the 2 rescue breaths, your eye should always be on the diaphragm to confirm the upward and downward movement of the chest, confirming that you have really applied the 2 rescue breaths correctly. Now, to give the internal chest compression, which you know the case of life here, 30 external chest compression to make CPR effective. You locate the lowermost rib, run your hand upwards, and come to where the rib meets with the breastbone. And at that point is where we have the sternum. It is at that point that pressure is applied to effect external chest. Place the heel of your hand, the index of your finger, as now bring the other hand on top of this other hand, your hand. Make sure you get close to the casualty so that your hand can be straight. Your hand and back is straight while you now apply pressure, giving this casualty 30 external chest compression thus. Now, you must press, while giving the pressure, you press up to 4 centimeters deep so that you can restart the technique. Do not give external chest compression to a casualty that is not breathing. A non-breathing, a breathing casualty, a casualty that is breathing. Don't give external chest compression to a breathing casualty. Who you give a external chest compression is a casualty that has circulation. That and the casualty. Now, another question comes: when do you stop CPR? Well, once you start effecting CPR to 30 external chest compression, you don't stop until the casualty is revived. Another first aider takes over from you. You will do it till medical help or aid arrive. And also take note in everything about first aid, where your first aid mission end is when you must have handed over the casualty to the next line of medical care, which is either the hospital, the doctor, or the ambulance that have come for your aid. Stand up the CPR and recovery position. Please, we need some questions in case you need any clarity.
Okay, thank you, officer. This is the slide. Thank you for that explanation. But I want to ask, because I may be thinking in the same direction as they are doing. If we have a child, maybe a baby, or an infant, how do we actually carry out CPR? Because I know I mentioned it.
All right. In an infant, the procedure is still the same. 2 rescue breath to 30 external chest compression. The only difference you will have is in an infant, you use your 2 index fingers to do it.
Around, up in the bushes, up in the trees.
Some people use some people can use the thumb to give the external chest compression. Then the rescue breath is the same. 2 rescue breath to 30 external chest compression. The only difference is in infant, you use your 2 index finger or the thumb. But in a child, you use 1 hand to give the compression. These are just the difference between adults, infants, and a child. Please take note. If you are giving the kiss of life or the rescue breath directly, you must make the good use of disinfectants. This is to limit the risk of cross-infection. Most especially, maybe the casualty have problem in the mouth or something. Another thing to limit the risk of cross-infection, you have to avoid spill bodily fluid touching your body to limit the risk of cross-infection. I'll now pause for us to bring some questions so that we know how far we are moving.
Thank you, sir. Thank you so much. That's having said, I know network just wanted to make us unhappy, but I refuse to be on. Getting better now. So, having seen that, have any question?
Yes.
Is there anything you want to ask?
I have
Yes,
I have a question.
Please go ahead.
I have a question.
Okay,
Yes.
that's
He said
yes.
When you are trying to resuscitate a patient with the pressing of the chest, and he said 32 times. So I want to know. Okay, 30. Sorry, 30.
Yes, 30.
Then what is okay? What is the interval? Because I have seen a situation whereby a doctor was trying to resuscitate a patient, and after the 4th pressing, the patient came back to life. And now brought in oxygen. So you are pressed. What is the interval at which you check whether maybe the patient will come back? But if the patient is not responding, then you not continue. That's what I want to know, ma.
All right. The interval, as you ask, when once you start doing CPR, you talk until the casualty respond. That is number 1. Until another phase aider take over from you. There are some conditions that at first compression, the first the casualty will come up. It will respond very well. That is when you put the casualty in the recovery position. And I also said too, sometimes you may give the external chest compression, the casualty is not responding. Sometimes if you see the casualty being restless, if you give the first 80 external chest compression and you see the casualty being so restless, instead of being fully unconscious, you check, open the mouth and check. There must have been a foreign object in the mouth. There must have been something that is blocking the airways, that is not allowing the free flow of what you are doing. So once you remove that and do the casualty will recover.
Thank you so much.
Please, have I answered your question?
Yes, thank you. Yes, thank you so much.
All right. Thank you. So practically, like the officers, it is important that we know how those things we do it. Thank you, Mildred, for asking that question, because over time we've been having questions, but today it's obvious that we don't want to ask questions, or perhaps they will be asking of the questions later on, which is not a problem. There are people that may maybe watch the video, the network is clear, and ask their questions, but it is important that we note that you don't carry out CPR on a person that is breathing. That's to tell you something, that you have to be very conscious when you are carrying out the CPR, because if you are not observant and alert, you can still assume that the person is still unconscious, whereas the person has started breathing, and it's dangerous for you to continue doing chest compressions on a person that is actually breathing. It's bad. So when we do carry out that CPR with the 30 chest compressions and the 2 rescue breaths that we are going to administer, you are also observant, as also looking at the rise and fall of the chest, other things to ensure that the person is breathing. Sometimes if you cannot visibly access the chest to see rise and falls, it's very easy. You turn the back of your palm against the person's nose, just like this. It's easy. You would hear when someone is breathing, of course, you hear the hot air in case you are not able to really pull up the chest. So it's important while we do that we should be very, very careful so as not to continue doing it while the person is actually breathing, because it is bad. And some key things that we need to really take home. One is the CPR, then is the recovery position, as well as others. But those two are extremely important because, of course, it doesn't stay away from the exam settings. It does not. And for us to do well, then we have to. Thank you, officer. I don't know.
The infants, how many chest compression is the same thing?
Okay, someone asked that question that is in the chat box. So I wasn't actually looking at the chat box, but someone said in infants, it's the same thing. It's the same 30 and 2 rescue breaths. But the only difference is in the means with which you do it. You use your 2 fingers on an infant so that you don't break the ribs. An infant is still very fragile. So if you go and do what you are doing, 4 meters and all those, you want to, we are not going to help the situation. So that is just it. So that having said, officer, I think we should move to the next one.
All right.
So that we can, I don't want us to extend time.
The next thing we want to know is diagnosis. When we diagnose this here, the signs and the symptoms of any incident makes a good diagnosis. If you come to a scene of incident, the answers by, because you also often, I hope you've heard about the parties to incident. The parties to incidents are, we have the passers-by, we have the standers-by, the casualty, and we have you at the first aider. So when you come the history, the incident, was it an accident? And also, if you see around, that's something to tell you the history of what is happening. Oh, this person was have taken drug. Or you may see it, or the minister has stabbed him. That's establishing the history. The next thing that you see is a sign. Sometimes if you see the skip mark on the road, it is a. So there are signs, there are symptoms. The symptoms now have to do with the casualty's body. Maybe you touch the casualty body with the back of your arm and the body is hot. Sometimes maybe the casualty is feeling headache. Those are symptoms of maybe malaria or something. So the history and the symptoms you to know what to do, how to diagnose. That's what we need to know about diagnosing. Then the next thing I want us to share is casualty movement, manual handling of the casualty. In casualty movement, there's what we call tile. I want to believe you've heard about it. Tile, T-I-L-E, in the vertical office. Okay. Now, the T there, T on the tile as an acronym, has to do with what is the task? How do you assist the casualty? What do you have to do for the casualty? How do you move the casualty? The I is the individual. Okay? How is the individual? How is the casualty? Look, carry the casualty. How do you look the casualty? Remember, there are some casualties, when you see a casualty, you see will determine this thing or the way you handle and carry the casualty movement. For instance, if you come across a little carry the little child easily, there are some casualty you come see, you know that you're able to carry this casualty. Then you need, there are assists, there are 3 assists, casualty that 4 people carry. Then we are going to demonstrate that. See, please come. Didi, come. Didi, come. Come. Didi, come. This is and she has it will not be hard for me to carry. Okay, I will just hold her, make her stand, then I can carry her and move.
All right, thank you.
Now, this one is an adult. This one is an adult. He is above my carrying capacity. What do I do? Never walk alone so that you don't become the next casualty. You wanted to go and help a casualty, and you yourself you become a casualty. Help. Okay. Now, this is what we call 2-man assist. This man to walk, he has a disposition on one leg. Now the 2 horse now. We now have to move. There's a 1, 2 comes down. This time around, we want to carry him because he cannot move at all. That is a two, something like that. And if what's come to was that this guy, we cannot carry him the way we are carrying, you now bring in the stretcher. From the handles. Now, there is something I want to talk about this stretcher. If the two of us cannot carry this man on this stretcher, we will need more hands. And another two first aiders will join us at the brigade. But right now, we want to this casualty. Okay. Okay. You find there are two belts here. Okay. This is to hold the casualty firm. Then we are going to carry the squat. Ready, ready, split. Ready, ready, move. Okay. As you can see, that is how we load the casualty on the stretcher and we carry. But if the casualty, some other first aiders to help us, the picture of all this, never walk alone.
Thank you. All right, so let's take this one. Let's take this one. Thank you. All right, thank you so much. Do you have any question? That's what we just saw. Remember, I had told you that today we are just going to be looking at first aid. So it is important to see you first aid because not in your you can assist maybe your neighbors and people knowing that you should have the knowledge, expect that you should do something. So sometimes you need to improvise. Like I said, we have to and get things done because the bottom line is that we want to serve humanity, we want to serve humanity and we want to save lives. So is the one-man assist and the two-man assist. That's how it is called. So the first one you saw, we had an acronym, TILE. And you would have the slides, like yesterday we did that I haven't sent in. So they asked me for the specific one. TILE. The task I do is for team. who is he to get a house that does not weigh the cost and look at relating it. So before you carry a person, so that you don't become a casualty, you have to look at these things. Task ahead of me, how you look at the person, that's where individual comes in. And then the load is the person fat, person slim, you know, maybe yes, as I am. You want to go carry the person that is maybe 3 you are, of course, you know, you cannot do. So these are things you have to look at. And then the evacuation. How are you going to carry this person? Take note, we are talking about emergencies where you have to do a lot of improvisation because there are incidents that just happen. Maybe so you have to convey the person to the hospital. You need a stretcher and you need to think fast on how that's just practically that's what we just finished. We just finished one. Remember that you can always ask your questions in the those of you that have asked. You know, if I don't answer because I am always schedule, but why do I have to type schedule? It's because of you. So I have it to do as well. If you have, please drop it there. But for those that have been able to see this particular act play out, this particular scene we just did, do you have any questions? Is there anyone that wishes to ask any question or wishes to make any contribution? Because we are still open to learning, because we are not embodiments of knowledge. No single person has all the knowledge. So anybody willing to ask, anybody willing to contribute? They are told that from the beginning and up on today, I have not heard their voices, and that's not good, especially when it comes to assessment, assessing them, their final score. So please, does anyone have any contribution?
Okay, good evening.
Every other thing that is.
Good evening, ma. This is Kate.
Kate.
Okay, please, I want to, my question is concerning using, okay, let me assume that I'm alone in the house with maybe a sister or a brother, and person happens to maybe miss his step or her step, and the person has, in this case now, I'm the only person. And then the boy starts screaming, sitting something that needs my help. And then going there trying to assist this person. Happened that I'm the only assist this person at the moment. And this individual is heavier, or even to carry the person from that particular one to another position. At this point, what do I? That is number one. And another concerning, we're talking about that CPO until another first aider comes in to assist, or maybe the proper medical people. Then my question there is also that in a case where it's just me and the patient, and then I have done this CPR to the extent that I am tired, which I know I cannot leave this person to go and start looking for someone or something. Let's just say this is in a house where two people are being, maybe me and somebody, just that. In this case, what do that person, what do the first aider do at the moment? Thank you.
All right. Right. Okay. And you know, we have to weigh all the pros and the cons. So that that's a good question. Now, you know, the first thing we say when our capability of it, that's the first thing I want us to understand. Now, for you to think, you need help. Told me the scenarios involved. There is no way you can do it. You know what? Okay, let me rush or let me do what I can, try to get the person, especially spray. You know how delicate spray is. If that person is not handled well, it can worsen. So first and foremost and most important, something like that happens. Thank God it is free. It's not a life-threatening, at least immediately. It's not like breathing issues. So the most important thing that the first aider is supposed to do at that point is to look for help. There is no way you say you cannot see help. Even if it means you screaming help, it doesn't have to be another first aider. But in this case, you need help, someone that will give you that needed assistance that you need to convey. Never at all, no matter the scenario, attempt to rescue or to lead somebody when you know that the load is beyond you, regardless of whether you're alone or not. So the best thing you can do at that particular point is to reach for help, is to call for help immediately. You have maybe people around or anybody to help you, because you cannot. Since the ultimate thing is for you making that person get better, and then you are attempting to do it alone, will not achieve your objective. So why should you do it alone? You have to reach and call for help. That is the most important thing. So I don't know if that has answered your question. So, officer, you wanted to take the second question?
Yes, to add to what Madam Dorothy has said, if that is not safe for you to do, don't do it.
Same.
And if you know that you cannot do it well, don't just do it. But once you see that this load, remember that time, the task, the individual, the load. How is this load? Will I be able to carry this load alone? And don't tend to go to you cannot do, because you will become the next. There's a load that you want to carry. The next thing you will your way is gone. So please don't ever walk alone. Call somebody. Call for help. You can have neighbor. See, you as a case aider, the pass by around you, you can give them instruction, only use them to accomplish your first aid mission. Then your second point was about the CR, right? Mashi? The second question was about CPR.
Yes. The second question is, in a case where I'm with maybe only my sister or my brother at home, and then this person slumped, and maybe, let's just say, maybe we were eating and the person got choked and the person slumped. At that point, I need to maybe check what's the problem before I know this person stop breathing. And it's only me that is a first aider in that environment. And possibly, let's just say,
maybe we did not. Okay. Carry on.
Yeah, let's just say when this person slumped, and then I realized that this thing has gotten to the point that this person cannot breathe. And then I'm like, okay, since I know what I'm supposed to do as a first aider, I say, okay, let me try maybe to start the CPR when I've checked the vital sign and I discover that this person is not breathing. At this point, I'm the only person in the building. And then I am only, and this person in particular, I'm equally trying to help the person by conducting a CPR. How do, in a building where I'm alone, to get another at the moment?
All right. In first aid, like you could hear when I was explaining, I said you do it till medical aid arrive. You do it till the ambulance arrive. That presupposes that before you ever start CPR, you have already called for help. You have already called 999 or 112. You already called for help. Never you start CPR when you call for help. Why? Because what happens? That CPR you're doing, the aim of it will be in the hospital or the next line of medical care. It is imperative that before you ever start CPR, the very first thing you do is call. Even when you want to do choking, you want to treat someone that has choking, the very first thing is you call. Call first, always call for help first. So that is why we say, well, if you know that you cannot, if you know that you cannot contain, you don't start it. If you know it is better to do it well than doing it, and there are some blunders over it. So now, how would you feel if trying to back that in your hands that I don't do the Samaritan law, okay? But you emotionally feel fine, not feel fine. So the first thing you do is you call for help first. You can answer that question.
Yes, you have very much.
Thank you, Kate. Do we have any other question about how to do transfers? That's transferring a patient from the bed to the wheelchair. That's going to be not the first aiders only work this time. It's the nurse. The nurse is going to do that. To show you how you can lift without exerting pressure, which is very important. That the nurse will do it by next week. So, but it's important that we understand summarily what you have said, that let's not be helped. Let's not incur more, do more harm in the course of us doing, either doing more harm to the casualty in this case, or doing more harm to ourselves, whichever way we look at it. So thank you for that question, Kate. And I think Mildred too asked the question. So far, I have taken note of the 2 questions from those 2 people. What do we have next? Do we have any other person with a question? Do we have any question in the chat box? Please, can you check?
Yes.
Kate asked the question. So, question.
It's a control one nearby or food. Always someone nearby.
She's the same Kate that asked the question. So, Kate, you asked the question and then you answered. Thank you so much. You also said it there in the chat box. Aside that, we don't have anything. So quickly, we are just going to look at, officer, what is the next week?
Management of
severe blood loss. That's the last one. I promised you not exceed 8 o'clock, and I mean it because I know we need to rest. We've come a long way. So we are going to see how you can manage severe loss. Very quick recap of what we have done. The first aid aspect is actually important part of your question, and it's important you get it and you get it right once at a time before the exam. Thank you so much. Oh, bleeding! Wow.
This lady here has a cough and she is bleeding profusely. She's having bleeding.
Okay, please, officer, sorry. I like to. Okay, I like to carry everyone along, please. So please just tell me. I've just read comments box. Aminat, someone asked a question and she said, officer did not ask a question. So she's saying, what if there is no help? Officer, that question is for you.
He's
saying, what if there is no help from the help team that you have called? I know what she's trying to say, we are in. So what if you help and you call? I don't know the help she's talking about, or the ambulance. Really, what do you do? That's the situation we find ourselves, especially I don't have to say we have this. That's the situation we find ourselves. So as much people, that's why before you even start, you have to, or by the time they have to maybe feel their, as they like to say, feel the plans. There's no feel before they get the feel. And then do all the normal things they need to do listening, or you still continue. That's why CPR, learning how to do it is very, very important. We advise that you can practice, but don't practice on your children. Don't practice on someone that is living. Then you want to practice, wives want to practice on their husbands or on their children, please. Don't practice living, but you can take note of it. Then you can practice using maybe a pillow, if you have a pillow, throw pillows like you lock your and you practice makes perfect before you actually go for the issue. So I don't know. You see, that's the problem. We are all adults. Then we keep talking and talking. I don't know how to keep saying the same thing. I don't know how to keep repeating this because I just expect that it's money. So if we need to mute our mic to mute it, we shouldn't inconvenience. I don't know how to. I cannot overemphasize that what we have for the last this evening.
All right.
Okay.
And you talk. After this, take this or move to the medical facility. Then you will encourage her to raise the hand to support. The movement to a medical facility is not immediate. Take it down and his or her. All that comes to you. Remember, do not assume the work of a nurse because you are not one. You are only a face aider. And assume the work of a doctor because you are not one. When they go down, the sterile dressing here will be done by the nurse there in the hospital. They will take the professional care of the casualty. All you do is work of a face aider. You do work as a face aider ends when send this person to the medical facility. Thank you.
Okay, so you have to clap for me. Thank you. So we haven't seen that. I think that should be, we should almost draw the curtain on that. I actually thought purposefully because of what like I promised. So we see how long we have. 5 minutes. Good. So having seen that, is there anything wrong? I needed some comment, observation, or any comments. Is there anything wrong with it? Because we had a lot of theoretical explanations and teachings all along, training. So what is actually wrong with that? Who can tell? Already I saw someone already tried to say.
Hello.
Someone already asked who has the Infinix.
Hello. Can you hear me?
Who is using the Infinix?
Yeah, hello, it's me, Promise, ma.
Okay, Promise, are you the one using the Infinix?
Yes. No.
Okay, I want to know who is using the Infinix phone.
I don't know.
I don't know if it's
I just want
Are
to.
you using?
No. Hello, ma.
I'm not using Phoenix. I'm
using the Phoenix. Okay, then it's not you. Okay, I'll find out who is the Infinix, because the Infinix person actually said that thing that I wanted to hear. But go ahead and ask your question or make your contribution, please. Yes, please go ahead. Sorry, I just wanted to know who was using the Infinix. Please go ahead. Sorry for that interruption.
Okay, ma. Thank you so much, ma, for your time. My reaction is can we attend to a casualty without our gloves? Is it right?
Okay. That's what I have to tell officer that I don't use the gloves. Today's network has just been so I'm not even sure if people are following me or not. And I find out and I said that's why it was in the stars are getting many. They actually be able to fulfill my promise. But however, I'll try. So
All right.
we need to have 3 stars.
Okay.
So you cannot. I purposely said that should be done. On no account should you attend to a patient, especially when you are dealing with bodily fluid. It could be maybe bed, proper bed making or doing any other thing. But when you are attending to the patient, any fluid, saliva, blood, anything in your gloves. Your gloves should be your best companion. So thank you for spotting that out quite early. And I know many other people had something to say that, well, maybe they didn't just want to say. So having said that, let's just have, in the next 2 minutes, let's just have a little rundown of everything that we have done this evening. We have done triage, 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 and with that triage is a word that means sorting, to sort. So in first aid, we are very particular about triage because we are not partial.
Mix your phone.
I don't even want to talk about phone again because
why
people
is
are
it
just
so
not
difficult for them to
complying.
mute their phone now? They are distracting us. It's bad.
Simple instruction. The collective
from
thing to
Ayo should mute his phone or is it?
Gifts, Ayo, that's the one. Gifts. Please help us. We are almost done. So I just want to give a rundown because maybe network did not permit you or something. I'm not just going to take your time for too long. So let's mute so we'll be on the same page. Now we talked about triage, like officer said. It's a term that is very important. It's situations where there is an accident, maybe a serious accident, and you see someone bleeding, you see another person broken bone, you see another person unconscious, you see people with different issues. So that is where your knowledge of triage comes into play. You now sort them according to the percent life threats. You understand? So when you put all of them, you know that the person that cannot breathe has more of the needs urgent attention because breathing is very, very easy for the person to just so in a particular hierarchy or a particular category, so that it's your brother that is having broken bone, and you say, oh, let me leave this person that is unconscious, that has breathing problems, and move to my brother that has broken. No, it is one thing. You shouldn't be partial in the healthcare when you are doing healthcare business. So hands bleeding and so on, like we heard from officer. Then the blueprint is the head examination of a casualty, head to toe. You examine for anything that is the usual sign for you to understand. Then we looked at bandaging too. We have different bandages, which is important that you have it in your first aid box. depending on the situation that you have, the challenge you have at hand, so you know the bandage to use. But every first aider is advised to have a triangular bandage, just as you were shown to have the triangular bandage. So after that, we have the draft C, the Dr. ABCD. I like to call it draft CD, but you can say Dr. ABCD using the acronym. For danger, the D is the danger, check around for danger. Either you take the casualty away from the danger, or you take the things that are dangerous away from the casualty and yourself as well, so that you can stay safe. Then the R is for response. You have to tap, shake the person. Hello, can you hear me? Are you okay? You tap the person just as you saw shown as. That is the R. If the person is okay, the person will say, or the person will try to, or if the person is unconscious, of course, you know the person response. You have the head, and then you check the airways. You tilt the head just as you saw them. And after that, we have talked about to see whether there's movement in the diaphragm, the up and the down. When someone is breathing, you know, or you put your face by the person's nose, you hear the hot air coming out. You know, okay, this person is breathing. Then we talked about circulation, checking the pulse. We even said we should check our pulse, but I don't know if we checked the pulse. Normally, over the years, the participants do check their pulse. So today, network played a funny one on us. So you check the pulse with pulse. Rather, we have the carotid, we have the brachial, we have different pulse areas in our bodies. In fact, 22. If a person is so you check for circulation. If you find pulse, then even if it's anyhow, that person still has the chances of coming back. Then we have defibrillator 2, defibrillation, which is the last. Now that defibrillation uses a machine, AED machine, is called an automated external defibrillator. It's actually a machine that you use. I have the video. I'm going to send it to you with the others. The TAL, the full acronym of TAL, and then the video for the AED, the use of the AED. So that is defibrillator to tell you remove the button, do this. It tells you, gives you instructions. So it shocks the heart and restores it back, the electrical function back for the person on the fine day. So we did that. So that is today. And when the person has some pulse, the next is put the person in a recovery position, the position where the person stays and takes time to recover before paramedics actually come, or the ambulance or whatever. So we also talked about the CPR too, the CPR cardiopulmonary resuscitation, and we did say 30 chest compressions and 2 rescue breaths. In adults, you interlock your hand and ensure your hands are straight, and do just the way our officer did justice to that, Officer Wilson. So then for children, you use one hand. For infants, you use 2 fingers, or you use your thumb, because they are very fragile, so you have to be careful. So having said that, that's CPR. We say continue until paramedics come. Do not stop. If you are tired, we have this 2-man CPR. That's where you have another person continue. Where you stop, the person can continue the CPR if you have help. And of course, you should have help. Then we have the TILE. We talked about that already. The TILE, the individual, the load, the evacuation. How do you take the person out of bed? Use the stretcher, and so on. Then the manual movement, 1-man assist, where you just one person. We have the 2-man assist, where the 2 people we can carry. I don't know if we did that. The one you can carry. Did we do that? Okay, fine. So when you carry, this one carries, and then you can lift the person comfortably. Then also understand that before you lift a person, you understand what the person's challenge is, so that you not lift a person that has spinal cord injury. People that have spinal cord injury, you have to be careful the way you lift them, because any little mistake, their bones are displaced. So you need to be careful. That's where blueprints comes into it, and you actually knowing what is the challenge that person has before you do these things, not just blindly. So diagnosis to the scene to see an empty container. Sometimes you even see a written suicide note from somebody. That is something that gives you an insight as to, this could be the problem. And, that's why people that are into crime, some people that are into crime, they capitalize on this fact. They know that when the police comes or anybody comes and they see anything, it can even be a wrong form of death, but they'll see another means there. Maybe they see a note written by anybody, or they see something there. So they build upon those things that they see at first glance. Do you have any questions?
Okay, good evening, everyone. This is Kate. This is Kate. Please, okay. My question is concerning the CPL. You said when doing for an adult, you into your children. For children, you use one hand. So I want to ask for the children, like from what age to what that before using one hand?
All right.
And that is not, then that is number one. And the second question I'm asking is, somebody drop it in the group. I don't know whether the group we use as a disinfectant when you use your mouth for CPR without using the mask. That is the question that the person dropped.
All right. Your first question for the children from 6 to 12.
Okay.
6 to 12 years old.
What do we have?
So then your second question is about
sorry. Sorry, so below 6 years is the one that you consider as an infant?
No, but I am telling you that between 6 to 12, you're talking about the child.
Yes.
You're talking about the child. But
for the one hand.
Yes, infant is between 0 to 2 years.
Yes.
Child. So you can always use your discretion to do this. School, place the age limit on doing this. But we are going to let you know that for an infant from 0 to 2, that you will have to use your 2 index finger or the thumb. Remember, sometimes you can see an infant that will warrant you to use the 2 index finger. You can see the other one that will warrant you to use the thumb, knowing fully well that the thumb here is stronger than even your 2 index finger. So it's discretional, but the age limit should be 3 to 0 for infant. Then from 6 is a child. That's down in between now is where you do discretion.
Yes. Thank you, officer. I think that's the only question she asked. Okay, so what we are trying to say is infants.
Sorry, the second question is
what about the disinfectant?
The second question.
Okay, disinfectant. Okay. When you want to do CPR for anybody, rescue grade, we're talking about rescue grade here, not external chest compression. Rescue grade, you must. It's a must that you use disinfectant. And that disinfectant you use is the methylated spirit. It is methylated spirit to limit the risk of cross-infection. Because place restricted is on wounds. And not all wounds, but fresh wound. It is not out of place for you to use methylated spirit or TCP on an old wound. Remember, we can also use things like hydrogen peroxide on old wounds, but not a fresh wound. So on a fresh wound, water is the best for now.
Okay, thank you, officer. So, kids, are we good? Are we good with that?
Please, can I ask?
So,
I need clarification on
So,
that is 0 to 2 years and 3 as a 6 of 3 to 6 years like that.
That's what they say. You should use your discretion now.
okay, see, let me tell you something. Okay, I know why we are concerned. Now, let me explain. Officer already explained. Some things in first aid is not cast on concrete, like we said. What do we mean by discretion? Just as you take your eyes and visualize a task that you want to carry, you see a person that you know your strength cannot carry, you know, I need to call for help. You also visualize and see, when you see an infant cannot really be contested because, of course, 0, a new baby, 6 months, 1 year, 2 years, fine. Now, there is why we cannot categorically tell you that this is child between 3 to 6 is that most times under statistics and having carried out statistics, we've observed that 3 to 6 is most times in between. You can see some children, maybe like he has said, that look stronger. The idea of using this one thumb and 2 hands depends on a person's physique. That's person's, I don't know, her body. That's how the person is. Yes. You can run into a child that is 3 years or even 4 or 5 years. You know, still you are not supposed to use one hand because that person is still below. But you see how the child is, you see the child's capability, you see that is a strong child. And in such a situation, nobody needs to tell you that you cannot fingers of depression. Very important. You have to tell you that 0 to 3, in between 0 to 3 years. You use the 2 fingers or you use a thumb. Then from 6 is a child, so you are not scared to use one hand. Then in between 3 to that 6, you look at how the child is, you look at the physique before you can actually decipher and tell yourself which will be better, depending on the child's physical features, depending on the strength, depending on what you have assessed and seen, that this cannot carry the child. This one is better. I cannot use it to be too hard on the child. That is where discretion comes into the picture. So I don't know if that's good enough. Osareme.
Hello.
Okay, she's saying that, officer, she's saying that in the process, because we are supposed to check for the pulse. So if you don't see the pulse, maybe checking for the pulse, you cannot feel any pulse. What are you supposed to do? Should you go ahead with the CPR?
Okay. Doing CPR, remember something transpired to doing CPR. And if you check and the casualty is bleeding, you put the casualty in the position. Look at the pulse. Now, let me tip in one thing again for you. I had a scenario in one school I went. A girl fainted. When the girl fainted, I now get into that scenario. When I checked, she was not breathing. But before I do CPR, I check pulse, and the pulse was there, but she was not breathing. I now say, I wonder, what is it? What is wrong? I now discovered that she was punched on the nose. She had a blue on the nose, and the blue on the nose, and the swelling on the nose blocked her nose and blocked the airway, was gone, so that she could not breathe from the mouth. If you cannot breathe with the nose, you'll be forced to use your mouth to breathe. So when I delved into external chest compression, I think I've said that now. I saw her restless. She was so restless. When I now stopped and really checked again, you must do a secondary survey to make sure that you know why he or she is not responding before you go for rescue break. Now, when I now discovered that the tip was bombing, I opened the mouth and do the next external check, and she came up immediately.
Yes, so
she came up.
I think what she's asking is if there is no pulse,
the heart has stopped functioning, and that person is unconscious, so you go to CPR direct. So
okay, I don't know. Osareme, I don't know who asked the question. Please, do we have any other question? Because I thought it's Osareme. I've seen that in the chat box. Any other question, please? Or has everybody gone? Have they all left me?
No, we are here.
Okay.
Hello, may I ask that question? Hello.
Yes,
Why I asked the question, I work in the hospital and I've seen cases where they're brushing someone, and normally we have to check to be sure that that person is still breathing. And they just come, they'll just check. They'll check for pulse, and next thing they'll say brought in dead. I'll not be like, I thought maybe they're supposed to do CPR.
No, that's it.
So that's why I'm asking.
Okay, thank you. Who is that funny person? Osareme. Who is that? Please let me know the person's name. So that I will know the. Okay, Osareme, thank you for that. Yes, it's true. It's true. It's true. That's why whatever you learn, it's good to learn and learn well. I have heard this thing severally that many people in the mortuary, I don't know, many people in the mortuary, I've heard this, but I don't know how true. That most people that are confirmed to be taken to live not dead. I don't know how that is true. I've heard such things over time. So whatever we do, we should do it right. That's why you take your time to do it. If a first aider has to follow all those protocols to confirm if a person is conscious or not, how much more of a person that is actually a professional in the field, like maybe a medical doctor or a nurse. So I think, Sareme, you have work to do. You have work to do after this training. However you want to do it, steps. Just try to, create some form of awareness. People should do what they have to do. We can't just tick someone gone when the person is not gone. We have to do all the work we need to do. Thank you. Thank you so much. Another question. I don't know. I guess I heard Madam Ubezi, so I don't know. Who else has a question?
Yes, this is Kate. I just want to say a little thing concerning that what the person has just said now. Just an experience here. Let me say in my place of work, we all heard about this, what is it called? This Mohbad, this popular musician that died last year. During the flying news that was flying over the internet, they said that when they confirmed him dead, that he was not dead, that they saw he was breathing inside the car, he was shaking, all those. That was all the news that was flying over the internet. At some point, I was like, how would this be true that somebody that was not dead was confirmed dead, and people seeing it in the car was now saying that they saw that this person was still alive? I wasn't too sure about that until when I started working in this place, in the environment where the incident actually happened. And that was when I got the whole information that this patient in particular was confirmed by the medical doctor that he was dead on arrival. But we, the public that heard it online, we were told that the person did not die, that they buried him when he was still alive. Do you get? So I'm just trying to, because of what she said, is the reason why I bring this topic. So most of the time, we just get information that is not accurate, and then we drive with that. We just carry it on our head. So that's just it. Thank you.
That's the truth. For that issue, I wouldn't know, because it's still a case that is still on ground. It's also here and there. So I cannot really say, I don't know whether he actually died or he didn't die. I just hear what I heard, as everybody heard. So I don't know, but the fact of the matter is, whatever we need to do, we should do it well. If we have to check and confirm that someone is actually not alive again, it should be by a coroner, it should be by a certified, someone that knows how to do it. And that's why when you're in any profession, it is important that you put in effort to learn the things you need to know, because it's easier for someone that is not in the health field to just confirm someone that the person is gone. But when a doctor, a person that is actually tested and trusted, is assumed, in quotes, to have the right knowledge to do that, the person says the person is gone, the person is not gone, it's not always a good thing. It's a bad stamp on the medical field. So however it is, we just have to do what we have to do. Just as all other anomalies we have been having, so is this one. So we just pray that God will help us. The bottom line is we should do these checks. Check the pulse, even for someone around. You can have someone that is unconscious. Do these checks even before the paramedics actually come, because when you do the checks, you already have your own of the current situation before the person is even taken, and the real one, not fabricated one, the real one, So thank you so much, Kate. That's having said, if you don't want to also see the chat box, thank you for staying with me up until now. Please, the media guy, can you help me confirm how many participants are still online now? Because it's past 8 o'clock. Obviously, some people would have said, oh, Dr. Mrs. Dorothy should just let them, go and rest. So thank you for the 17 people that have remained up until now. I want to say a big thank you to you. You may not it may look as if you are just maybe acting drama or doing something, but I'm telling you, first aid is important, because when you need it most and you don't have the knowledge, you will continue to flog yourself for the rest of your life. It has happened to me when I needed to do what I needed to do, but I did not have the right knowledge, and it has cost me a lot. Until today, I still look back at it. So it's nice that you stay with me. Next week, we are going to have we are done with anything first aid. So next week is going to be the life vital signs, how to do the transfers, the skills that you need to know, proper hand washing, and so on and so forth. So on that note, would like to say a big thank you to all of you. I don't know if anybody has anything to say. Maybe I should ask Kate. Yeah. So Kate.
Yes, so I have something to say.
Kate, what you have to say. Let me
What I want to say is, maybe you can ask me a question later if you want to, but this one I want to say, I'm super excited to see you. Like, it made me feel like we are here together.
Yes, so yes.
Because I know that many want to say,
yes, a very beautiful woman. A very beautiful woman.
Thank you very much, Dr. Dorothy, for all your commitment for our own success. We are grateful.
Make sure that someone will tell me that I look very beautiful. And I'm happy today to hear that comment. Thank you very much. everyone. And a big thank you to my team too, the Officer Wilson, Officer Mary.
Your voice.
Yes, now.
Can you
Ah.
I'm telling you.
This night I'm already. Thank you. I really appreciate all the time. I would like to have the opportunity to see everybody as well. It's just that you are seeing me, that I've not seen, and I only know a few that have done trainings with me before. So I would like to see everybody because I know that the voices I'm hearing on the platform, I cannot miss to see the faces. Thank you so much. On that note, please do have a lovely day. I hand over to Andy Smart Solutions.
Yes, ma. Please, I paid 100K into your account, but you are yet to confirm it, ma. Today.
Yes, I know. Who did that? I don't. Someone paid. Yes. Forgive me. You know what normally happens to me.
Aminat.
Oh, Aminat. Yes. With the blue, blue. For them in the afternoon, and I have to tidy everything for today, so I was a bit busy. We'll get to that. Thank
We
you
love
so
you
very
so
much,
much, mommy.
We
love you so much.
She's such an amazing person. She is too much. My daughter is too much. You are the best.
Ah.
I know my goat is loading. For some of them, I told that time to join and they were scared.
Doctor.
Now they're smiling.
All of them are happy. We are trying to
smiling. They were afraid of losing their goats. They will give me that goat.
And we are telling them, don't worry.
Give me their names. If they don't give you the goats, their certificates will not get to. They just give me all their names. All those people that we are
good. That's
and
good.
those that missed will be regretting by now.
Yes.
They will regret. I'm telling you.
Wow. Thank you so much, Doctor. Thank you so much. Our wonderful participants, I want to ask you, how many stars should we give Dr. Mrs. Dorothy? How many stars?
1 million.
5 stars. Uncountable.
You have said it all. Doctor, you see why we always call on you. Doctor, we will always call on you to come and take trainings because you have never disappointed. Thank you so much. Really appreciate you. Our participants, thank you so much. We are going to, next week, we are wrapping everything next week. Take care of yourself and God bless everybody. Good night.
Yes, good night.
Good night,
Jovita.
Thank you. You guys are the best.
Good night. See you tomorrow.
See you.
Good
Bye.
night.
Bye.
See you.
Bye.
Have a wonderful
everybody.
night.
Good night.
Bye,
You
everyone.
too. See you tomorrow.
Are you there?
Bye. Love you all. Love you.
Love you too. See you.
Bye.
Bye.
Bye, everyone. Bye. Good night. See you next week.
Good night. Bye.